All right, I'm back with Dr. Felipe Restrepo for the second part of a couple of cases that he's willing to share here with us on the important topic of autotransplantation of teeth. And Dr. Restrepo, let's get to it. What is the second case you have for us?
Okay, this is the second case. This is the second possible clinical scenario. Is when you have a freshly extracted tooth because the tooth has bad prognosis, and you already have this socket. There is a freshly extracted socket, and you can modify it in order to receive the donor tooth. So in this particular case, it's a 27-year-old female. We did a third molar to a first molar position. We use periapical X-ray, also panoramic X-ray, CBCT, intraoral scanning, and dynamic navigation device. This is the case. You had the distal root is fractured. This was already diagnosed by explorative surgery also. So since she has a third molar here that is unerupted, we decided to use that as a transplant. So we did the planning, and what we get from the planning, as you saw in the previous case, we do the surgery virtually with the help of my friend Dr. Julian Gonzalez from Mexico. And we position the tooth in the specific place that we wanted, both buccolingual, mesiodistal, and also angulations. And we create this new STL. This is the new STL of the already transplanted third molar. This is what we put into the Navident. So here we have it in the Navident. We have this green silhouette of the transplanted tooth that enables us to modify the socket three-dimensionally with a surgical burr. This is just so you can see the perfect match of the DICOM in the upper left with the STL. You see the perfect match between the two files. This is done automatically by the software on the Navident. So this is the clinical scenario. We had the fractured tooth. As I told you, the third molar was unerupted. Then we extract the tooth, we modify the socket, and finally, we place the transplant with the splinting. And then 3 weeks later, I did the root canal treatment, very small access. And you can see only 3 weeks afterwards, what a beautiful periodontal healing. And these are the X-rays. This is how you can see it after surgery. Then it's the root canal treatment. As you can see, I'm having an isolation in the next tooth, in the second molar, so I don't touch or manipulate the first one. And as you can see, it's a minimally invasive access, small tapers, because we want this to last. And here we have the 2-month follow-up. Look at the enamel dentin junction, the level what it was, because we place it as low as we can, and then the tooth starts erupting until it reaches contact with the upper tooth. And look, 2 months later, it's erupting. And this is 6 months later. Look the level of the dentin enamel junction. As you can see, already periodontal ligament space formed, newly bone formed, and this is only 6 months afterward. And this is the clinical view 6 months later. Look, the tooth already reached contact with the upper molar, and it looks perfectly normal. So opposed to the previous case when we have to do this only restoration, in this case we didn't have to do anything. It's just a small class 1 access that was filled with composite, and the patient is very young and is absolutely happy with this result.
Wow. That is terrific. I mean, this is a talk about minimally invasive going on. I mean, this is as minimally invasive as it gets in terms of being able to replace a tooth for a tooth and be able to get such a great job of not even having to do a crown. It was a nice fit to begin with. And I like the idea of submerging it and allowing it to come into its natural occlusion. You still did have your non-rigid physiological splint for a couple of weeks, right? Despite the fact that there was a larger opening than not? Did you have a couple of weeks of physiological splinting on this tooth as well?
Yeah, 2 week splinting with orthodontic wire and resin composite.
So 2 weeks was enough. Okay, perfect.
Yeah, that was enough.
Yeah, so I think this is really a great summing of the two different case scenarios, one involving a fresh extraction socket, the other one a tooth where there's an eventual space that needs to be filled. And, in both cases, I think that this was really a wonderful service to the patient, of minimally invasive manner of replacing a tooth with a wisdom tooth that wasn't needed, treatment planning it perfectly. Here you use dynamic navigation to get a fairly close approximation of the shape of the tooth from that which you printed into the bone, so that it ends up being a very close match. But alternatively, I guess if you don't have access to that, you're going to have to use a little bit of good old school, just touching and just kind of trial and error with your printed tooth.
Yeah.
But the key there is that it helps reduce with dynamic navigation, it helps reduce the amount of fidgeting you're going to have to do in order to match it, which is good for reduced trauma to the surgical side, as well as the fact that you get a closer approximation and you don't end up having to accidentally perforate the buccal or the lingual cortical plate, which can potentially happen. And speaking of that, if you do end up perforating, especially in that previous case with the concavity on the bone, is it the same problem that you get sometimes with implants with thread exposure, or you don't happen to get that as much with natural teeth, would you say?
No, there's no problem here, because we have a sound periodontal ligament and cement. As long as you have that, you're going to have bone either way. And also that you don't perforate the flap. If you don't perforate the soft tissue, the healing is going to happen. Actually, I have some cases with very high bone damage, very severe bone damage, and the whole bone is restored by the periodontal ligament, because that PDL is the main bone mediator.
Yeah.
The responsible for the bone. How do you say this? I can't have that word on the tip of my tongue right now. The main responsible for bone metabolism is the periodontal ligament.
Right.
Okay? As long as you have that and you have soft tissue covering the root, the hard tissue healing is going to occur.
Right. Yeah, for sure. And PDL is critical, and it's very important for the overall physiology and dynamics of tension, force, and bone metabolism, and the way it forms there. So this is terrific. And in terms of recall on this one, do you have any longer recalls or any CBCT sections post-operatively of this area?
In this particular case, I just like this one because it's so conservative, and this is 6 months. We're waiting for the 1 year recall. Perfect. At the probably second semester of this year.
Well, terrific. I must say both of your young patients who were edentulous in this area must be ecstatic to have their own natural teeth kind of saved and merely auto-transplanted from one side to the other. And this is a great service in Medellin. I'm sure you probably are one of the few people that is providing the service, so this must be really wonderful. Dr. Restrepo, I want to thank you for sharing your vast knowledge in this area with our viewers. And if they want to get a hold of you, I'll make sure they're able to get a hold of you in the comments below, or I'll share your information with them as well here below this video. Yeah. And I want to thank you again for doing this, and we're looking forward to having you sharing your larger presentation with our residents soon.
Thank you so much for having me, and can't wait to be there with your residents and show them the full presentation so you can see more follow-ups. We have CBCT follow-ups up to 15 years, as I told you, 5 years, 8 years, different cases, but these are two pretty nice cases I wanted to bring to this interview that are very, very good examples of the two possible clinical situations or scenarios that we face. The important thing for me is that you like it, and hopefully your viewers would like it too, and that endodontists have this as an option. We're taking the whole of this. We're getting in charge of this because we know a lot of periodontal ligament healing because of the trauma. We all are trained in trauma. And perio guys are great, but they are too busy with implants. So this is what we need to start doing. We need to start doing this more as endos. And this is very rare in our side of the world, but in Asia, this is everyday work, for instance.
Yeah, we should remain specialists in saving teeth. And with that final word, I want to thank you again. And for Vivo Dendo, I'm Ali Nase. And until next video, let's save something.